Hi, now I'd like to talk about high-risk perinatal care, Chapter 12 in your text, and it's on gestational conditions. Within this chapter, we're going to talk about hypertensive disorders, hyperemesis gravidarum, bleeding issues, urinary tract infections, including pyelonephritis, and trauma during pregnancy. I've decided to break these up into mini chapters. This one's going to be on hypertensive states of pregnancy, so I'll get going on that. I'll publish it. It'll be a little bit easier in a smaller file, hopefully you can download, and then I'll do the same with the others. So gestational hypertension is hypertension that develops after 20 weeks of gestation of pregnancy in a previously normotensive woman, meaning someone who has never had hypertension problems. So she came into the pregnancy and maintained the first 20 weeks without having any blood pressure problems, and now all of a sudden after 20 weeks she develops some. And we'll talk a little bit more in depth about gestational hypertension. But next I'd like to mention preeclampsia. That can be either mild or severe, and that's the development of hypertension and proteinuria in a previously normotensive woman after 20 weeks of gestation or an early postpartum. In trophoblastic disease, which we'll talk about, preeclampsia can develop before 20 weeks gestation. Then we come to eclampsia, which is basically preeclampsia with seizures. So it's the development of convulsions or a coma not attributable to other causes in a preeclamptic woman. And those other causes might be other seizure disorders prior to pregnancy. So chronic hypertension is hypertension present before pregnancy or diagnosed before 20 weeks of gestation, and it's persistent after 12 weeks postpartum, meaning they came into the pregnancy or it was diagnosed in the first 20 weeks. That would be chronic hypertension, and it just maybe has gone undiagnosed to this point. Or perhaps they knew they had it. And it can last after 12 weeks postpartum. Superimposed preeclampsia or eclampsia. That means chronic hypertension, and then it's superimposed with preeclampsia or eclampsia. So in women with hypertension before 20 weeks of gestation, and now all of a sudden they have protein in their urine. Or in women with both hypertension and proteinuria before 20 weeks gestation, it gets worse. So meaning it becomes complications of the hypertension, or the severity of it, I should say. I want you to take notice on table 12.1 on page 303. It defines these characteristics, and also review box 12.1 on obtaining the blood pressure. That's going to be very important when you're making decisions based on perhaps medication decisions, treatment decisions. You need to really understand how to take an appropriate blood pressure for a patient with this condition. So please review box 12.1 on page 303. This slide gets a little overwhelming, I think, when you first go to look at it. But basically, the cause for preeclampsia is unknown. Despite the years of research, no cause has been identified. But they do see some of the underlying mechanisms. They know that it's from vasospasm and endothelial cell dysfunction. This manifests in some of the conditions on this slide. So if we kind of lead through it, I'm going to lead you through this. So we have hypertension, so vasospasms and decreased organ perfusion. So vasospasms, that's a spasmodic event happening in the blood vessels, and it decreases perfusion to the organ wherever those blood vessels are leading. So you end up with symptoms, hypertension as we talked about. Also uteroplacental spasms results in intrauterine growth retardation. So if you think about the blood vessels going between the uterus and the baby through the placenta, if those are spasming, they're going to be narrowing, decreasing the amount of blood flow to the baby, causing intrauterine growth retardation. When we talk about the kidneys as another organ, the glomerular damage that's done, you're going to see increased plasma and uric acid and increased creatinine levels, and you're going to see decreased urine output. The cortical brain spasms are responsible for the symptoms of headaches and the hyperreflexia and the seizures. The retinal arteriolar spasms that has to do with the eye spasm to the retinal artery, and that has to do with blurred vision. And then the scotoma, which is like, we always ask, do you see spots in front of your eyes, any dark spots in front of your eyes? So that's what that means, kind of a dim vision type situation. And then hyperlipidemia. When the liver ischemia is especially concerning, and that has to do with the nausea, vomiting, which can be normal pregnancy signs and symptoms, but when it gets into epigastric pain, which is caused from liver damage or hypoxia to the liver, and it's usually in that right upper quadrant, that's from swelling and inflammation and kind of damage going on in the liver. It can also result in elevated liver enzymes. The intravascular coagulation, that has to do with the blood, and that's the hemolysis of red blood cells, and the platelet adhesions. That creates all sorts of cascades, giving you a low platelet count, and can result in a bleeding condition called DIC. Increased factor VIII antigen, those are again clotting disorders. Increased permeability and capillary leakage can result in proteinuria. Generalized edema. Pulmonary edema, which you see in severe preeclampsia, resulting in dyspnea, and a hemoconcentration of an increased hematocrit. The one I want to point out on this slide, we talk about chronic hypertension, which, just to reiterate, that happens prior to the time the woman's pregnant, or it develops during the first 20 weeks of her pregnancy, and it will also go on after 12 weeks postpartum. Gestational hypertension, that happens after 20 weeks of gestation. So it's elevated blood pressure after 20 weeks of gestation. But that's without proteinuria or edema. Okay, so that's kind of a mild situation. This used to be called pregnancy-induced hypertension, but I think it was 2002 they changed that terminology from pregnancy-induced hypertension to gestational hypertension. It's a little more benign, again, but once they start adding the protein and the edema in the urine, proteinuria and the edema, then we jump into the preeclamptic states. So for preeclampsia, like I mentioned, it's mild and severe. If you look on page 304, there's a great comparison chart on table 2.2, and it differentiates the difference between the two. So, new onset hypertension, proteinuria, and after 20 weeks. Those things are all vital to be diagnosed preeclampsia. And eclampsia, again, has all those other symptoms, but it also has seizures. So we're going to start out talking about mild preeclampsia. And here we have the signs and symptoms. If you get a diagnosis of a blood pressure of 140/90, and those are taken 2 times, about 6 hours apart, that means it needs to remain elevated on 2 separate occasions. You're going to have +1 or +2 proteinuria, so when they dip the urine, it's going to be +1 or +2. If they do a 24-hour urine, a qualitative analysis is going to show greater than or equal to 300 milligrams of protein. That would also add to the diagnosis of mild preeclampsia. In the mild facial and hand edema, that's going to be linked, if you look back at that slide a few minutes ago when we talk about all the different issues going on. Normal, healthy, pregnant women get leg edema. They may get a little bit hand edema, their rings don't fit, all that kind of stuff. But this is more significant. This happens when women get facial edema. Women, just normal, healthy, pregnant women, may have weight gain, and it may show on their face, but they're not going to get facial edema per se. That's looking at, if you see someone with that and they say, oh my gosh, my face is so swollen today as opposed to any other day, that you want to think about, especially if her blood pressure is elevated, you're going to start thinking about signs for preeclampsia. And the weight gain is due to that edema that we talked about. Management is kind of conservative as long as there's no liver or kidney dysfunction. In this next slide we'll talk about the management. The patient can be treated at home, but there's a lot of things that have to happen. This patient has to be a very compliant patient. The blood pressure, we want it to be less than 150/100. The The proteinuria has to be minimum. They have to have normal liver tests, normal kidney function. If you look on page 308, 309, and 310, there's some great patient education boxes that I want you to read through. Some women have trouble relaxing at home. They have a lot of social issues, work, finances, childcare. Those women, they're not going to be good candidates to be managed at home. So they're going to have to really weigh out her home situation as well. If the woman's symptoms increase, they're going to be monitoring this patient every week. They're going to be doing blood work on her, checking her liver, checking her kidneys. It's going to be a very tight schedule. Yeah. They're going to have to closely monitor the fetus. They're going to be doing probably ultrasounds. They're going to do fetal activity studies depending on how far along the woman is in pregnancy. They're going to put her on bed rest. The ideal position is going to be in the left lateral position. We want to maintain a quiet environment. She needs to rest. So they're going to monitor her blood pressure daily, protein in the urine, daily fetal kick count. Remember we talked about that a few chapters ago. They're going to do neurostatus. They're going to assess her deep tendon reflexes and check for clonus. Your book gives a good demonstration of the clonus, and that's when you kind of hyperflex the foot and then let it relax, almost like you were doing the Hohmann sign, but you're going to hyperflex it and then hold it just for a split second and then relax it. And if it normally in a normotensive patient it's going to just relax down, or someone without clonus is just going to relax down, but with someone with clonus it's going to actually have beats. It's going to kind of pulsate all the way down, and you're going to count those beats, and that's how you measure clonus. Bed rest, like I mentioned, in the lateral recumbent or the left lateral side. That helps promote perfusion to the organs and to the fetus. To promote rest and enhance renal function and removal of sodium, always the lateral recumbent to avoid supine hypotension. I think you've had that drilled in you through adaptive learning about the supine hypotensive. Okay. Possible medications. They're going to give a low-dose antiplatelet medication. Because of the tendency for the platelets to cluster along those arterial walls. They're going to caution the patient it is a powerful drug, and they probably will give some antihypertensive medications. Your book gives a good description on those medications. Let me see what page it is. Oh, I don't have the page in front of me right now. It's on page 314, table 12.5. So if you'll take a little bit and look over those medications, they're probably medications you're familiar with already, but I'd like you to review them. And for nutrition, we're going to want to really promote good nutrition. They don't have a sodium restriction because they worry about hypotension. You want to make sure she's drinking. You don't want to do a lot. You can have her add salt, but just don't overdo it. 8 to 10 glasses of water every day to promote renal and bowel perfusion. And what else here? Emotional support. Stress the importance of she has to be compliant with this. Truly, whether she's hospitalized or whether she's trying to take care of herself at home, she needs bed rest. She needs to try to get financial situation in order. Childcare and work arrangements, that's sometimes very difficult and sometimes easier on the patient if she's hospitalized. Expectant care begins. Management during labor is focused on preventing progression of the disease. Okay, hypertensive states of pregnancy and severe preeclampsia. This one we have hypertension, a blood pressure of 160 over 110. That's an elevated blood pressure. Again, they want 2 different readings, 6 hours apart, on bed rest. So this isn't a patient you want up moving around. She's very hyperreflexic, but with guarding proteinuria, +3 or +4 when they dip her urine. If they're going to do a 24-hour urine, which I don't have listed here, I believe that's greater than 5 grams, so 5,000 milligrams of protein in that 24-hour urine, as opposed to the mild preeclampsia, which was 300 milligrams. This is going to be 5,000 milligrams. Extreme edema, pitting edema. They have a great picture in your book again as to the depression when you're going over a bony prominence, especially on the legs. I've demonstrated many times, I should say, to you guys during clinical if you've had me for clinical. So you want to look for pitting edema versus non-pitting. Again, the edema is moving up, face and hands. And also, unfortunately, when that happens, you can get it going into the lungs as well, resulting in pulmonary edema. Liver involvement, we talked about the epigastric pain, which is from liver hypoxia. They get nauseated, vomiting. Headache and visual disturbances secondary to the cerebral edema. And they have those retinal spasms, which result in that scotoma, or the dark spots in front of the eyes, or the dimmed vision. Marked hyperreflexia, as I mentioned a second ago, and that has to do with the clonus. I should say is manifested by the clonus and secondary to cortical brainstem irritation. So really, critical is the pulmonary edema. These patients are high risk, and this is a life-threatening disorder. The management is based on disease severity and fetal age. And with preeclampsia, the only true treatment is delivery. So birth of the fetus is the only cure. But unfortunately, if women get diagnosed with this around 20 weeks, they have a long way to go. That baby still is not going to do better outside. We want to try to maintain that pregnancy as long as possible. Let's see, fetal age, I mentioned, significant in determining viability. So these patients are absolutely going to be admitted to the hospital. If they're greater than 36 weeks, they will probably deliver the patient. If they're less than 36 weeks, they're going to do more conservative care. They're going to be on complete bed rest for the CNS irritation. They're going to decrease the stimuli. They want them to be in a dark room, keep them on their left lateral position as much as possible. We're going to pad the side rails possibly for seizure precautions. We're going to weigh the patient daily, take vital signs. We're going to do intense fetal monitoring. Serial lab values for the mom on her liver, hemoglobin, hematocrit, magnesium levels because she'll be put on magnesium sulfate, platelet levels. They're going to do 24-hour urine to check for protein and specific gravity and creatinine clearance, again monitoring her organ function. All of these resort back to that one slide where we have all the different organs that are affected by these vasospasms. We want very accurate I&O, so they'll probably put a Foley catheter in the patient. They want to make sure they're getting at least 30 cc's an hour out. Nutrition, moderate to high protein, 8 to 10 glasses of water a day. She may be NPO initially, of course, especially if she's having a lot of nausea and vomiting. And we might see decreased peristalsis because of everything going on. Emotional support. Ooh, this is very distressing socially. It causes upheaval of the family. Medications have side effects. They just don't feel well. They're going to be doing fetal heart tones if they're hospitalized every 4 hours at least. They're going to be doing a biophysical profile, trying to establish the fetal well-being. And then, depending on the gestational age, they'll do non-stress tests. That's going to be, especially after 32 weeks, they can really start to do those non-stress tests. Remember how we talked about the accelerations in a term patient? We want a 15 beat by 15 second, lasting 15 seconds. Those kind of accelerations help diagnose positive fetal well-being. But in a premature, around 32 weeks, they're looking for a 10 beat by 10 second acceleration is going to be a positive sign. And vital signs, blood pressure at least every 4 hours. Some of the antihypertensive drugs, again, were listed on page 314, such as hydroxyline, labetalol, Aldamit, and Procardia. Magnesium sulfate. I know you guys made a drug card on that, and that's great. We're going to want to look for signs of magnesium sulfate toxicity. So hopefully you guys can by now state what those are. Calcium gluconate is the antidote if someone has too much magnesium on board. The critical critical criteria you're looking for is that they lose their reflexes, and they also, the respirations are below 12. When that happens, those women are at great risk. They're going to want to have that on standby, the calcium gluconate. Be ready to give it. If you observe anything, and you're going to be really critical when you're looking at this and truly counting for a full minute. You're not estimating. You're counting those respirations and praying that she's above 12. It's very scary when they start to feel like that. So mag sulfate is a smooth muscle relaxant. Primary purpose is to decrease seizure activity. The therapeutic levels are 5 to 7, so before we initiate it even, we're going to draw a blood level to see what her baseline is, and then we're going to titrate it according to that. They usually give a magnesium sulfate bolus, and they give that over 15 to 30 minutes, and then they generally set it at about 2 grams an hour, and then we go on from there. We do those reflex tests, we do her vitals, watch them very closely. Okay, one of the worst things about mag sulfate is that when you first give it, when you're giving that bolus, the women feel horrible. Sometimes they taste a little metal taste. They feel hot, flushed. It's just a miserable feeling. If they were feeling okay before, they're not going to feel well after that bolus. They're just going to feel absolutely horrible. So emotionally, you're going to be there to support those women. Now I'd like to talk to you about eclampsia. Preeclampsia with seizure activity is life-threatening. This is when it involves acute cerebral edema. The symptoms are seizures, convulsions. They can go into a coma. And maternal mortality is caused from cerebral hemorrhage, circulatory collapse, renal failure, or complications from HELP or DIC. Fetal mortality from hypoxia and fetal acidosis, especially if the baby's immature. Vaginal delivery is always preferred, but cesarean if it's too premature. If this woman gets admitted before the seizures, but just in general preeclampsia, and if she requires hospitalization, or if its blood pressure is getting worse and all the symptoms are getting worse and she's too early to be delivered, they're probably going to start corticosteroid therapy, giving mom injections so she can help to mature the baby's lungs. That's usually betamethasone that they're going to give the mom to help mature the baby's lungs. Generally, the surfactant doesn't fully mature until about 36 weeks of gestation in a normal healthy mom. So if she comes in under 36 weeks, that's going to be one of the primary goals. If it looks like delivery is imminent, or if the eclampsia or preeclampsia condition is getting worse, they're going to want to make sure they get those babies' lungs mature as fast as possible. Management of eclampsia, seizure precautions. Prior to the seizure, it can occur up to 48 hours after birth as well. Blood pressure rises sharply, the temperature rises, the mom may feel like something's happening. She may have headaches, really, really bad headaches, nausea, vomiting. You're going to try to keep her safe during the seizure, tonic-clonic seizure. You're going to maintain her airway. Try to get her on her side. Give oxygen if possible. Try to prevent aspiration. Such a scary thing when you see this. They're going to try to monitor the fetus as much as possible. Check for vaginal bleeding. Make sure she's not abrupting. With all these spasms, you can have the decreased perfusion to the uterus and the placenta, and it could actually abrupt. In postdictal confusion, semi-comatose, hearing is the last to go and the first to return. So remember, she has CNS irritability. You're going to want to maintain a very quiet environment, not a lot of talking, limit the amount of conversation. You're going to keep her NPO immediately after, and we're going to try to monitor the fetus. Get heart tones as quick as possible after the seizure. See how the baby's doing. Okay. During labor, we're kind of going to do all of these things. If a regular preeclamptic patient and a hypertensive patient, we're going to use all of these. IV Pitocin, we may need to use some IV Pitocin to stimulate some labor. After birth, we're going to monitor the newborn for respiratory depression due to the magnesium that the mom was on, hypotonia, that means lack of tone, and hypocalcemia. For the mom, proteinuria with preeclampsia, we mentioned normal 24-hour collection is 300 milligrams or more of protein. Severe preeclampsia, we talked about 5,000 milligrams or 5 grams of protein in a 24-hour specimen. We're going to dipstick all urine samples. Edema, mainly involving the upper extremities and the face. Pitting edema may be absent or it may be pitting. She may have pulmonary edema. Going to watch out for any respiratory complications, any dyspnea, frothy secretions, anything like that. Cerebral edema that results in the CNS irritability, headaches, the spots in front of the eyes, something doesn't feel right. She just may have a kind of like a premonition or aura about her. Okay, let me see what else on here. Going to draw all these blood work. Deep tendon reflexes again. She's prior to the time of treatment, she's going prior to the magnesium sulfate, she may be hyperreflexic when you're doing the patellar reflexes. After that, after when she's on the mag, we're going to maintain hopefully some reflexes. We don't want them to get too low or to not have any reflexes. This is kind of a cool graph. Just it shows you the blood vessels and then how that baby's the way this has to do with the supine hypotension, and then you can see how they're kind of crunched on the C, on letter C, the diagram C, the inferior vena cava and the aorta. But then when you shift her off to the side or put a wedge underneath her, you can see how those blood vessels open up and they're going to allow better circulation. Severe preeclampsia, one of the symptoms is HELP. It stands for hemolysis, elevated liver enzymes, low platelet count. The symptoms, it's secondary to the diagnosis of severe preeclampsia. Now this is kind of different, that you're not necessarily going to see a elevated blood pressure. She may have kind of vague symptoms. Diagnosis is made by lab values. The red blood cells hemolyze in a blood smear, low hemoglobin. They're going to have low platelets. Liver enzymes are elevated, the SGO, TSGPT, and the LDH. Treatment for this is delivery of the baby, quick as possible. Fresh frozen plasma, and transfuse platelets as well. They'll give medication to help maintain, and they're going to try, if they have, like I mentioned, if they have to delay the birth, they're going to give corticosteroids to the baby to help mature the lungs so they can get her delivered. She has got to be in complete darkness. Anything is going to irritate this woman. It can take, even after she delivers, quite a while for all her normal liver enzymes to get back to normal. I had a friend who had that happen, and I believe it was over 6 months, and she still had some elevated liver enzymes and things weren't quite right. But she was up in an intensive care unit on her left side. It was a very scary time for her. She wasn't sure the baby was okay because she hadn't delivered yet. As a labor nurse, we were going upstairs to take care of her in the ICU unit. Family, it's very limited visits. If she has other kids, it's very hard on them. She needs quiet. She needs peace. It's a very scary time in her life.